Hello, and welcome to my presentation. I'm Joelle. I'm a perinatal nurse. I have experience in NICU and postpartum, and I've been doing that for coming up on 17 years. I'm also the Director of Education for the Academy of Perinatal Harm Reduction, which is a new organization that I started with a couple colleagues, and we provide evidence-based training, education, and support to families and providers, and really anyone involved in perinatal substance. We come at this from the lens of harm reduction, which for those that are unfamiliar is at its simplest just what it sounds like, reducing harms associated with risky behaviors. Harm reduction also respects the efficacy and value of people who use drugs, believing that they are worthy of love and respect. I have no disclosures. I like to begin each of my presentations with an acknowledgement of the Indigenous people upon whose land the presentation is taking place. This was originally prepared for the Anne Spring meeting, which was going to be on Maui, so I've chosen the Hawaiian kingdom. I invite you to join me in paying respect to elders past, present, and emerging. In 1983, the Hawaiian kingdom was overthrown. Despite Indigenous resistance, it became annexed 5 years later to the United States and was governed as a territory for 61 years. In 1959, Hawaii became a state, and its residents finally enjoyed all of the rights of full citizenship. Less than half of Native Hawaiians initiate breastfeeding, which is significantly lower than the general population. The infant mortality rate for Native Hawaiians is almost 3 times that of the general population. These kinds of health disparities are not related to some flaw in genetics or some poor cultural practices. These are the direct results of experience of trauma and violence during invasion, occupation, and cultural genocide. Healing this trauma and a return to traditional practices has been identified by Native Hawaiians as a piece of the solution to these health disparities. So there's a few questions that we need to ask when we're evaluating the safety of cannabis exposure via human milk. Firstly, does cannabis affect maternal health? Does it affect lactation? Is it present in human milk? If it is present, is it absorbed by infants who consume that milk? And lastly, and most importantly, does this exposure have an effect on infant health and development? So let's dig right in. So whether cannabis affects maternal health is a bit beyond the scope of this presentation, but I will say that cannabis can have positive and negative effects on the health of anybody who uses it. One thing that I hear often is that we should prevent people who use cannabis from providing milk to their infants because of intoxication or impairment in parenting. And when I hear that, I always want to ask how formula fixes this alleged intoxication or impaired parenting. It doesn't. It's really important that we interrogate and evaluate these assumptions and things that we've just heard so many times that they become true in our minds. So, does cannabis affect lactation? We know that infants exposed to cannabis via human milk wean at similar rates to unexposed infants. And you may notice in this presentation that I use some old citations like this one from the National Institutes of Drug Abuse in 1985. And the reason for that is because there hasn't been as much new research as you'd expect. Seems like every other month we get a new meta-analysis or systematic review, but most of them are rehashing the evidence that already exists. So what I do is I take these systematic reviews or even statements put out by American Academy of Pediatrics, Academy of Breastfeeding Medicine, and others, and I follow the trail of their citations until I find original data. Oftentimes it's review after review after review, 4 or 5 times before you get to the actual study that everybody's been talking about. So that's why some of my cited articles are so old. There's also evidence that cannabis is associated with a decrease in prolactin, which is one of the hormones that affects milk production. Now, these studies were done in either men for men and non-lactating women. So they do tell us that if you're not breastfeeding or producing human milk, your prolactin levels may be lowered by cannabis use. They don't tell us if that occurs in people who are actually lactating, and they also don't tell us if it does occur in lactating people, does it actually affect um, the, the milk production process? So a lot more research needs to be done there before we can make any practical use of this information. Cannabis passes into human milk at a rate of about 1% of the parent's dose. And we know this we've known this for decades. It's a classic paper that's cited so frequently. I encourage you to read it. It's by Dr. Perez Reyes, and it is a half-page letter to the editor of a medical journal, where this doctor describes two cases where human milk tested positive for THC and infant urine and feces tested positive for THC. It's also been confirmed by more recent research as well. So we know it's present. Do infants absorb it? Infants are very bad at absorbing medications and other substances through their gastrointestinal tract. So what we see is about 1% of the parent's dose gets into milk, and infants only absorb about 1% of that. So their dose is about 1,000 times less than whatever the parent was exposed to. And even if we extrapolate this by weight, that's still a much smaller dose than would cause effects in the parent. We know that THC and other components, and especially metabolites, are present in the urine and feces of infants who consume this milk. And this, especially the presence of metabolites, tells us that it's not just passing through their system unchanged, but that they're actually using it and it's being metabolized by their system. So the main question that we want to address today is, does postnatal cannabis exposure via human milk affect infant health and development? This is a much tougher question than you'd think, because most of the research on cannabis is on prenatal exposure. There's very little research that tries to separate out prenatal and postnatal via human milk exposure. The two studies that are cited most often, and indeed the only studies that are cited by the American Academy of Pediatrics, are NIDA 1985 and Astley 1990. And whenever I see the NIDA paper cited to support a claim that breastfeeding with cannabis exposure is unsafe, it confuses me, because these researchers found, and I quote, no differences among groups of exposed and unexposed infants. So that right there should give you pause. The other paper is from 1990, and we'll talk about that a little more in a couple slides. Those results are a bit more complicated. And like I said, these are the only papers cited by AAP to support their human milk prohibition. These are also commonly cited by many, many other of our most trusted publications. Speaking of our most trusted publications, you're probably familiar with Dr. Thomas Hale's Medications and Mother's Milk. I know I am. It's on every unit I've ever worked on, and it is easily the best reference text for which medications are safe for providing human milk, as long as you're not talking about anything illicit, such as cannabis or the other criminalized substances. For cannabis, it is terrible. I've posted an article here that I worked on with a journalist, which describes my correspondence over several months with Dr. Hale and his team. During that correspondence, they agreed that they had misrepresented the evidence and overstated the risk. However, they declined to make any changes. A couple years later, they did drop it from L5 to L4, but I don't pretend to take any credit for that. I also heard, on the condition of anonymity from one of Dr. Hale's team, that he agreed that cannabis should be L2 or L3, but was afraid of saying so for fear for his professional reputation. So I encourage you to check out that article, and there's a link there at the bottom on the slide. So the reason I want to talk about this paper from 1990 is because it's really typical in a lot of ways of research around cannabis and the perinatal period. And one of those ways is that it has a very small sample size. Even when you're looking at larger cohort studies like the Ottawa Prospective Prenatal Trial or others like that, they have a very large cohort, but a very small percentage of that cohort was exposed to the substance in question. So, for example, in this paper, we have only 17 heavily exposed infants, which is defined as exposure greater than 14 days a month. We have 38 moderately exposed infants, and we have 81 unexposed infants as a control group. Another thing that occurs in this paper that's also really common in other studies on cannabis is that they weren't able to fully control for sociodemographic factors. We know that things like childhood trauma, exposure to violence, poverty, poor nutrition, um, lack of enriched home environment all has effect on early infant development. And when we can control for these things, we can tell if what we're looking at is sociodemographic factors or whether it's actually effects of the substance exposure. Another thing that's really common in perinatal substance use research and cannabis research in general is that the people that we're able to study are the people who have been caught. So this typically means these are folks that have involvement in social services or the legal system. Those folks also tend to have a lot more negative social determinants of health. So that's something to watch out for when you're reading research. So despite all of the things that we just talked about, most of the children in all three groups tested within the normal range of human variation. So for this test, normal range is 85 to 115, and anybody below 70 would be diagnosed with a significant developmental delay. As you can see, everybody scored above 70, every single child. And so a lot of times what we see when we're looking at these studies is a slight difference still within the normal range that the researchers then interpret as being a severe or serious deficit. So it's like saying your student who got a B plus is severely impaired because they didn't get an A like my student. And this just doesn't make a lot of sense. There's a very big difference between statistical significance and clinical significance. Another example of this is something you see in research often where there will be maybe a 50 to 100 gram difference in birth weights that's presented as a serious deficit. However, if you have a baby that weighs 3,100 grams and another baby that weighs 3,150, is the first baby impaired or is there something wrong with them? Should we intervene? No, it's just the normal human variation. That's really important to remember when we're looking at studies like these. By the way, I want to make sure to be clear, just because the moderately exposed infants scored higher than the unexposed infants, I am in no way advocating that people should use cannabis while they're providing milk to their children. Cannabis is one of those substances that tends to create very polarized viewpoints. So we have people on one side saying, it's the greatest thing ever. Everybody should smoke weed from the moment they wake up to the moment they go to sleep. And then we have people on the other side saying, it's horrible. It's going to create a generation of monster children and we have to stop it now. And neither one is correct. What we need to do is objectively look at the evidence and make interpretations based on that. And that is what we should base our policy on. After one of my presentations, I had a woman come up to me and proudly tell me that she smoked cannabis every single day of her pregnancy and her son turned out fine. And I told her, I'm so happy that your son is fine, but I don't advocate for any recreational substance use during pregnancy or the lactation period, including caffeine. So now we're going to talk about a case study. And this is somebody that I took care of myself. And I'm just going to take a moment to pause my screen share so that I can read something that I wrote about it. Sarah looked up at me, her eyes filled with tears that never dropped, and said for what felt like the 1,000th time, well, it is what it is. I fed her 4-day-old baby a bottle of formula as she went over to the sink and slowly poured her freshly expressed colostrum down the drain. The longing in her face as she watched me feed her baby was unbearable. My own eyes filled with tears as I thought about how I never became a nurse to do this, to knowingly and intentionally harm my patients. All this because she had tried to do the right thing by being honest with her doctors about having used cannabis a few times for nausea in her first trimester. She would have to dump her milk for almost 2 weeks until she gave 3 consecutive negative urine screens. During this time, she and her baby would be deprived of the irreplaceable health benefits and bonding experience of early breastfeeding. Earlier that day, I had argued with the neonatologist, the charge nurse, and anybody who would listen. I pointed out that Renee's urine screen had been negative at the time of delivery, that the baby's urine screen had been negative. I presented evidence that even if she was still using it, cannabis in breastfeeding has never been shown to do any harm to mother or baby. I pointed out that the National Institutes of Health, LactMed, Medications in Mother's Milk, and Academy of Breastfeeding Medicine do not consider cannabis a contraindication. I compared our response to tobacco versus cannabis. Nothing I said made any difference. They all looked at me like I was crazy and told me to stop talking to her about it because she could use something I told her to present a better case for herself in family court, where her baby had been appointed a lawyer and she had not. The arguments used to defend such uninformed policies are the same in every hospital I've worked in. When one of them is disproven, another will be used, indicating that maintaining these discriminatory practices against people who use drugs, and especially women who use drugs, is more important than actual facts. They tell me it would be disrespectful to law enforcement. So I got a letter from the local chief of police that said they defer to us on health matters. And then it became, well, it's contraindicated by Hale in Medications in Mother's Milk. After I corresponded with Hale's team for months, pointing out his obvious and blatant misrepresentations of the evidence. And he changed it from L5, contraindicated, to L4, possibly hazardous. It turned into, well, if she's using cannabis during pregnancy, we have no idea what else she's doing. We also have no idea who's driving over the speed limit, or eating unpasteurized cheeses, or having long soaks in the hot tub while they're pregnant. And we shouldn't. Our job is not to surveil and punish our patients. Our job is to provide information and support so that people can make the best healthcare decisions for themselves and their families. Policies like this send the message that women are required to behave in a certain way, and if they don't, we'll punish them and their children. The next argument was it's contraindicated by the American Academy of Pediatrics. I pointed out that AAP has grossly misrepresented the data and presented no evidence to support their recommendation. When this last one comes out, then I know I've lost. Well, that's our policy. Cannabis is easily the least harmful illicit substance, and it is associated with the most unwarranted stigma in breastfeeding. These prejudices persist in healthcare providers not because we're hateful, ignorant people, although every group has its bad apples. These persist because the people who hold these prejudices inform policy on every level. Because we do not interrogate assumptions about people who use drugs. Because we don't question practices that we do because this is the way we've always done it. Because until it touches our own lives, it's just words on paper, and that's unacceptable. Sarah and her baby were eventually reunited, but her milk supply and their bond were never fully restored. After spending the first few months of her son's life wondering if this appointment or that nosy neighbor or this late night knock on the door was the signal that indicated she was about to lose her son forever, she struggled to form a strong bond. After being told that she and her milk were such a danger to her son that it required a police presence in the hospital, she felt unworthy of motherhood. She was never offered lactation support or any other resources. She spent months in therapy for post-traumatic stress disorder related to her birth experience and subsequent child welfare surveillance. Her son is now happy, healthy, and hitting all of his milestones. But Sarah will carry the scars of this trauma with her forever. Trauma that that you, that we all inflicted upon her. I don't apologize for becoming emotional because in our emotion lies our greatest strength. In our emotion lies our greatest motivation to do what's right for our patients and our communities. The implications of human milk prohibition in the presence of cannabis exposure are far-reaching and have profound effects on the lives of our patients. Babies and families lose the benefits of breastfeeding, which we know provides countless health protections to our children, including decreased risk of childhood illnesses, decreased risk of sudden infant death syndrome, better state regulation, bonding, and it provides benefits to the parents too. Aside from the health benefits of decreased bleeding and faster healing, it protects against perinatal mood and anxiety disorders, and it also provides a priceless motivation. Providing human milk to your own child is something only the parent can do, and that can be a powerful motivation to maintain positive changes such as abstinence from illicit substance use. This is a motivation that should not be wasted. When we prohibit people from providing milk to their children, families are traumatized, subjected to surveillance, and stigmatized. I am haunted by the parents I've harmed and scarred, the babies I've robbed of nutrition, bonding, and later health, and the families that I have helped tear apart. So now for your action items. The first one is just something I want you to mull over the next few days to weeks. And think about, how is your practice different between cannabis and tobacco? And is that supported by the evidence that we have? We know that babies exposed to tobacco via human milk have higher incidence of sudden unexpected infant death, asthma, other childhood diseases, ear infections, and lower IQ as they grow up and start going to school, as well as increased behavior problems. The evidence for this is strong. The evidence for harm from tobacco is slim to none, The evidence of harm from cannabis is slim to non-existent, and yet our policies. Speaking of policies, make sure your facility has a policy about substance use and breastfeeding, and make sure that it is evidence-based, robust, and compassionate. Make sure your policy reflects mandatory reporting laws accurately. These can be tough because they vary widely by state and seems like they're changing them every year or two. To find resources to help you understand the law as it relates to pregnancy, breastfeeding, and substance use, check out advocatesforpregnantwomen.org. Familiarize yourself with handouts from Elephant Circle. This is an organization based in Colorado that does advocacy for health and legal issues for pregnant and parenting people. They have excellent handouts on cannabis. And one thing that I like about their handouts a lot is that they have input not just from doctors and nurses, but from lawyers and social workers and parents and everybody. So you get kind of the whole picture rather than just the doom and gloom that we're typically exposed to. Don't test infants or pregnant people for substance exposure in the absence of a clinical reason. I would argue that more than 99% of the urine drug screens and other blood and body part tests that I've performed or been a part of in my career were not necessary for a clinical reason. For example, you have somebody coming in who is taking prescribed medications for chronic pain or methadone, and we test this person and it comes back positive for methadone. And then we test their baby and it comes back positive for methadone. Why did we do that test? Did we do that to confirm that this person is taking their medication as prescribed? Or did we do that to provide documentation of infant exposure to substances so that we can give that to the social worker or the family court? If you collect information about your patients in the absence of a clinical reason and solely for the purpose of providing evidence in a court or child welfare proceeding, that has been found to be a violation of the Constitution. There was a Supreme Court case in 2001, Ferguson v. the City of Charleston, where the hospital had been drug testing certain people who came in. Guess which people? You're right. They had been testing certain people who came in to deliver their babies and providing those results directly to law enforcement. This was found to be a violation of their patients' constitutional rights to be free from unreasonable search and seizure. It's also a violation of the American Nurses Association Code of Ethics, where we are to advocate for our patients, not against them. Another thing that you can do is get involved with family court or the Public Defenders Association. I think that nothing has informed my practice in this area so much as knowing what happens after you make that report. It would be so wonderful if that report resulted in services and assistance and help for that family. But most of the time, it involves surveillance, punishment, and setting up insurmountable tasks for these families to accomplish in an already stressful time. You can also get involved with local legislative advocacy. Our lawmakers, for the most part, are not doctors or nurses, and they don't know what they're talking about. It is our job to inform our lawmakers about what policies would make sense. And it is our job to advocate that we stop doing policy that punishes and, and surveils our patients and start doing policy that works. It is our job to encourage our legislators to create policy that supports, not punishes, pregnant and parenting people. Punitive responses to perinatal substance use have been shown over and over again not to result in better outcomes for anyone, but to result in increased incarceration, increased child removal, and decreased prenatal care, because people who know that they're going to get in trouble for going to see the doctor are not going to go to see the doctor. Please feel free to contact me with questions about this presentation. If you'd like a more complete or an annotated bibliography, I also have policy templates for substance use and providing human milk, for maternal care, for infant care, and for reporting to child welfare agencies. I can also provide you with a more thorough debunking of claims from the American Academy of Pediatrics and others about breastfeeding safety with cannabis use. Or if you just need an outlet to share your experiences or talk, please let me know. I'm always available. Thank you for listening.